Hi, I'm Emily Allen, and this is my Case Connections 4 video. So to start out for case 1, they present a newborn girl that was normal at birth, but within 24 hours, she was experiencing lethargy, hypothermia, and apnea. They suspected a metabolic disorder and ordered labs. The case is asking which of these diagnostics would be best to distinguish a urea cycle disorder and a disorder in beta oxidation. Her blood workup showed that ammonia levels were elevated along with urine orotic acid levels, and that plasma citrulline levels were normal technically, but they're on the lower end of normal. And then the case also asks in this patient where orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So, starting off with that second question, ornithine transcarbamylase is most likely deficient. So, this enzyme catalyzes the step where ornithine and carbamoyl phosphate are combined to make citrulline. So, a deficiency in this enzyme would explain the increased ammonia levels, first of all, because ammonia is used to make carbamoyl phosphate. And then it would also explain the buildup of orotic acid because carbamoyl phosphate, when it's not being used to make citrulline, can actually go into a different process and make orotic acid. So if carbamoyl phosphate is building up, then orotic acid would also build up. And it would explain the lowered levels of citrulline because without this enzyme, citrulline cannot be produced. Carbamoyl phosphate synthetase 1 is least likely to be deficient because this enzyme um, helps in the production of carbamoyl phosphate. So a deficiency in this enzyme would cause a lowered level of carbamoyl phosphate, which would mean that yes, nitrogen levels would still build up, but it would not explain the orotic acid buildup. And then the case asks which diagnostic would be best to distinguish between a urea cycle disorder and a disorder in beta oxidation. So I said both urinary acids and blood glucose because urinary acids are a distinguishing factor in diagnosing this condition. Urine orotic acid and nitrogen levels would be high due to the accumulation of carbamoyl phosphate, while citrulline levels would be low. And this urine orotic acid is found by testing urinary acids. I also said blood glucose because um, and it can be used to distinguish between the urea cycle disorder and a disorder in beta oxidation because ATP is used in the formation of carbamoyl phosphate. So in the fed state, this comes from the diet, but in the fasted state, this comes from beta oxidation. So if blood glucose was high, that means that you're in the fed state. And if you were still seeing a deficiency and you were still seeing these abnormal levels of orotic acid and citrulline and nitrogen, even when blood glucose is high in the fed state and beta oxidation is not occurring, then you can rule out a beta oxidation disorder because beta oxidation is not occurring and you are still seeing the issues. Glutamine levels would not explain all of this patient's symptoms. So glutamine is broken down to glutamate by an enzyme called glutaminase. This reaction releases free ammonia, and this free ammonia is used in the formation of carbamoyl phosphate. But this would not explain all of the patient's symptoms because if there was a deficiency in this enzyme, then that means that there would be less free ammonia, so there would be less carbamoyl phosphate, so that would not explain the elevated levels of orotic acid. If this enzyme was upregulated, then there would be more free ammonia and there could potentially be more orotic acid, but there's nothing stopping the conversion of carbamoyl phosphate to citrulline. So that would not explain the lowered citrulline levels. And then serum fatty acids would not affect orotic acid levels because serum fatty acids don't have any sort of direct effect on the urea cycle. So then for case 2, they present a 4-day-old infant with a low birth weight. They found elevated phenylalanine levels, and a diagnosis of phenylketonuria was made. The case asks that as a consequence of this presentation, which amino acid may become essential. They explain that a phenylalanine dietary restriction was initiated and the phenylalanine levels dropped within the normal range. It asks what the potential causes are of the presentation of phenylketonuria. And it also introduces another patient that also had phenylketonuria. And BH4 loading tests were performed on both patients. And then it asks how you would summarize the results of this test for patient A and B. So to start off, what are the potential causes of the presentation of phenylketonuria? So first off, it could be a phenylalanine hydroxylase deficiency. So phenylalanine hydroxylase is the enzyme that catalyzes the reaction that converts phenylalanine to tyrosine. So a deficiency in this enzyme would explain the buildup of phenylalanine. It could also be a tetrahydrobiopterin or BH4 deficiency. So BH4 is a cofactor for phenylalanine hydroxylase, so that means that it would also affect the conversion of phenylalanine to tyrosine and could also affect the buildup of phenylalanine. So for patient A and B, they both did a BH4 loading test. Patient A did not respond well to the BH4 loading test. Patient A's phenylalanine levels still increased after the meal, even with BH4, but patient B showed an improvement in phenylalanine levels after the BH4 administration. So because of this, I said that patient B likely has a BH4 deficiency, while patient A likely has a phenylalanine hydroxylase deficiency. So patient B responded well to BH4 supplementation and phenylalanine levels dropped. Patient A still experienced an increase in phenylalanine levels following a meal. So with a phenylalanine hydroxylase deficiency, it doesn't matter how much cofactor you have, the enzyme is still not going to be able to work, and you're still going to see that increase in phenylalanine. With a BH4 deficiency, BH4 supplementation fixes the root of the problem. So it allows the enzyme to function normally again. So then it allows the conversion of phenylalanine to tyrosine, meaning that you would see normal phenylalanine levels again after the BH4 administration. So that's a way that you can distinguish a BH4 deficiency from a phenylalanine hydroxylase deficiency. So as far as treatment goes, in the case of a BH4 deficiency, you can just supplement BH4 and then phenylalanine levels should go back to normal. In the case of a phenylalanine hydroxylase deficiency, because this won't work, you usually need to do a diet low in protein and high in fruits and vegetables. So phenylalanine comes from proteins, so you have to avoid proteins, but you still need these in your diet. So often a low phenylalanine protein supplement is taken. So this condition can also lead to low birth weight, which was seen in this patient, a musty odor, and fair skin, hair, and eyes due to the lack of melanin production. So the other piece of this is that tyrosine can be converted into melanin, which is what gives pigmentation to our tissues. So with this deficiency, tyrosine cannot be created, so it leads to the lack of melanin. So, as a consequence of this presentation, which amino acid may become essential? So, tyrosine would become essential because phenylalanine is converted to tyrosine by this enzyme. So, deficiency would mean it could not be created in the body, which is the definition of an essential acid. It means that you need to obtain it from the diet because it cannot be created in the body. So they call this a conditionally essential acid because in normal functioning metabolism, tyrosine is a non-essential amino acid, but in this case, it would become an essential amino acid. And then to finish, I have my references.